Good evening, everyone. This is James Leckie, the college coordinator for ACFAOM. Thank you for joining us for this webinar, Billing and Coding, What You Need to Know for 2017 with Dr. Michael Warshaw. Just a quick introduction on Dr. Warshaw. He's a practicing podiatrist and a certified coder with over 25 years of successful coding, management, and training experience for podiatric practices. And his local and national views come from active participation as a practicing podiatrist and having the distinction of being a certified professional coder in years of serving as a national lecturer concerning coding issues. If you have any questions, please hold them till the end of the webinar. And you can submit questions using the chat function at the bottom. If you drop that down, you can send it to all questions to organizers and panelists only, or you can send it to send questions to staff, and we'll open it up at the end of the webinar. I'm going to go ahead and hand this over to Dr. Warshaw, and thank you all for joining us.
Well, good afternoon and good evening, everyone. I'm flattered that you took time out of your day to attend and watch and listen to this webinar. I am a multifaceted person. As James said, I am a full-time practicing podiatrist. I am a certified medical coder with several subspecialty certifications, but I primarily do forensic or legal medical coding. I get hired by attorneys, I get hired by medical practices to do audits and reviews and to review audits that have already been performed on the clients and the physicians or hospital groups. I'm an expert in all facets of Medicare, Medicaid, and commercial insurance appeals processes nationally and in all states. But the one thing that I do that nobody wants to deal with, and rightly so, is that I am an expert witness for the defense in federal and state civil and criminal issues. When a physician does something that is deemed to be inappropriate by an authoritative board or an authoritative organization, the doctor needs to protect him or herself from impending criminal issues where finances are going to be affected, and perhaps even the person could end up serving time in jail. My job is to make sure everybody does everything appropriately, and that is what I'm going to be doing this evening. Tonight's webinar, as James said, Billing and Coding, What You Need to Know for 2017. While there haven't been a lot of changes in 2017, the ones that have occurred are quite important, and I think it's important to know how to deal with them in an appropriate fashion. For 2017, there are new codes for hallux valgus, both diagnostic codes or ICD-10 codes, as well as procedural codes or CPT codes. As far as the new ICD-10 CM codes for hallux valgus, there are two, M21.611 bunion of the right foot and M21.612 bunion of the left foot. I have an issue with these two codes. When ICD-9 was in existence prior to October of 2015, we had an ICD-9 code of 735.0 for hallux valgus, which is a structural diagnosis code, and we had 727.1, which was a bunion. Well, very often when we would use the bunion ICD-9 code, we were rejected because it was interpreted as being more of a cosmetic issue than a functional or structural issue. Now, I don't know if any of you have tried using M21.611 or M21.612 yet, but my suggestion would be to still use the original ICD-10 codes of M20.11 for hallux valgus of the right foot, and M20.12 of hallux valgus for the left foot. As far as the CPT codes are concerned, the procedure codes, the CPT codes for bunion corrections or hallux valgus corrections and even hallux rigidus corrections have changed. It was a long time coming, and they changed effective January 1st of this year. Even though they've been in existence for 5.5 months, we are still seeing issues with them. 28289 is hallux rigidus correction with chylectomy, debridement, and capsular release of the first metatarsal phalangeal joint without an implant. This basically seems to be a more wordy, more specific description of the hallux rigidus correction with chylectomy that was in play prior to January 1st of this year with the CPT code 28289. When you look at the picture, oh, sorry about that. When you look at the picture in the in the CPT manual for hallux rigidus correction, specifically for 28289, it shows there is excessive bone or the presence of osteophytes on the dorsal aspect or the top of the first metatarsal phalangeal joint. When those osteophytes or excessive bone are removed, a chylectomy is performed, and it's appropriately coded as 28289. We no longer have the CPT code 28290. We now move to 28291, which again is a hallux rigidus correction with chylectomy, debridement, and capsular release of the first metatarsal phalangeal joint with an implant. 28289 was a hallux rigidus correction without an implant. 28291 is a hallux rigidus correction with an implant. When you look at the picture, once again, here we have a hallux rigidus situation where we have excessive bone or osteophytes in and around the first metatarsal phalangeal joint. Here they are on the dorsal aspect. When that joint is cleaned up and an implant, either a partial implant or a total implant, is placed into the first metatarsal phalangeal joint to correct the hallux rigidus deformity, it is appropriately coded as 28291. Well, we still have a 28292 CPT code, but it's changed. 28292 is kind of like the potpourri or the smorgasbord of hallux valgus corrections. It seems that 28292 is used for any hallux valgus correction or bunionectomy that does not entail an osteotomy. And when you look at the description of 28292, it says correction, hallux valgus, bunionectomy with sesamoidectomy when performed. So whether you do the sesamoidectomy or not, this code still works. With resection of the proximal phalangeal base when performed, any method. So if you want to get very basic, this code can be used for a simple or silver bunionectomy. It can be used for a modified McBride bunionectomy. It can be used for a McBride bunionectomy. It can be used for a Keller bunionectomy. When we go to the picture, they show you a few different variations. Here we have a bump of bone on the side of the head of the first metatarsal. If that bump of bone is removed, a simple or silver bunionectomy is performed, and it's appropriately coded as 28292. Here we have, in the bottom picture, the bump of bone on the side of the head of the first metatarsal. it's removed. The base or the bottom of the proximal phalanx is also removed in order to straighten the first metatarsal phalangeal joint. If this procedure is chosen to be performed, it is a Keller procedure, and it is coded as 28292. I also said this would be the appropriate code for a McBride bunionectomy. The bump of bone is removed from the side of the head of the first metatarsal. The conjoining tendon attachments of the adductor hallucis brevis are tenotomized, cut, or released to bring the great toe into a more straighter position. And whether you remove the fibular sesamoid bone, which would make this procedure a traditional McBride bunionectomy, or you leave the fibula sesamoid intact, which would make the procedure a modified McBride bunionectomy, 28292 is the appropriate code to bill. We no longer have 28293, nor do we have 28294. The next procedural code is 28295. 28295 is correction hallux valgus or bunionectomy with sesamoidectomy when performed with proximal metatarsal osteotomy, any method. Prior to January 1st of this year, if a doctor, a surgeon, decided to perform a base wedge, a closing base wedge osteotomy to correct a hallux valgus deformity with a large IM angle, there was no bunionectomy code. You were billing for an osteotomy of the first metatarsal, and any work that you would do to correct the quote-unquote bunion deformity was bundled with it. So essentially, you were doing twice the work for half the money. Now we have a CPT code for that procedure, and the code is 28295. The bump of bone is removed from the side of the head of the first metatarsal. A closing base wedge osteotomy is performed to close down the IM angle. This procedure is appropriately coded as 28295. 28296 pretty much stays the same as it was prior to the start of this year, but the description and the verbiage has changed. 28296 is correction hallux valgus or bunionectomy with sesamoidectomy when performed with distal metatarsal osteotomy, any method. We go to the picture. The bump of bone is removed from the side of the head of the first metatarsal, and an osteotomy is performed in the head-neck area of the first metatarsal to straighten the first metatarsal phalangeal joint. When the bump of bone is removed, a distal metaphyseal osteotomy is performed. It is appropriately coded as 28296. An example, of course, would be an Austin bunionectomy. 28297, once again, pretty much stands the same as it did before. This was a Lapidus procedure. Correction hallux valgus or bunionectomy with sesamoidectomy when performed with first metatarsal and medial cuneiform arthrodesis, any method. We go to the picture. The bump of bone is removed from the side of the head of the first metatarsal. An arthrodesis or a fusion is performed where the base of the first metatarsal articulates with or comes in contact with the first or medial cuneiform bone. This relates to 28297. 28298 is correction hallux valgus or bunionectomy with sesamoidectomy when performed with proximal phalanx osteotomy, any method. The picture demonstrates pretty much an Aiken procedure, A-K-I-N. The bump of bone is removed from the side of the head of the first metatarsal, and an osteotomy is performed within the proximal phalanx of the great toe to straighten the first metatarsal phalangeal joint. This procedure is coded 28298. The last first metatarsal phalangeal joint procedure specifically dealing with hallux valgus is 28299. Correction, hallux valgus or bunionectomy with sesamoidectomy when performed with double osteotomy method. Double osteotomy means two separate, isolated osteotomies that do not come in contact with each other are utilized to correct the hallux valgus deformity. And the CPT manual actually gives 3 steps of 28299. Surgical option 1, or the first example, of course, with all 3 of these, the bump of bone is removed from the medial aspect of the head of the first metatarsal, making it a bunionectomy. An osteotomy is performed within the head-neck area of the first metatarsal and within the great toe. This is referred to as an Austin-Aiken procedure, and it's coded as 28299. Surgical option number 2, an osteotomy is performed at the head-neck area of the first metatarsal and at the base of the first metatarsal. This would be categorized as an Austin base wedge or a base wedge Austin, and it is also coded as 28299. The last example is an osteotomy at the base of the first metatarsal and an osteotomy within the proximal phalanx of the great toe. It would be categorized as a base wedge Aiken. A base wedge Aiken is also coded as 28299. The next issue is an update of the 2017 CPT codes for bone biopsy. One of the issues that podiatrists have had for years when they biopsy a bone in the foot is whether to code it and categorize it as a superficial biopsy or a deep biopsy. We never knew if we were doing it correctly. Well, CPT has now solved that problem for us. Effective January 1st of 2017, 20240, biopsy bone, open, superficial, for example, sternum, spinous process, rib, patella, olecranon process. But here's the most important part: calcaneus, tarsal, metatarsal, and phalanx. Thus, if you are doing an open bone biopsy of any bone in the foot, it has to be coded as 20240, superficial. Why? Because the CPT manual tells us to do it this way, and Medicare and the commercial insurance industry rely on CPT. When you look at 20245, it's biopsy bone open deep. And as you can see, the examples of the bones that are listed here are not in the foot. The last issue that I'm going to talk about, and this is going to take some time, this has been floating around out in the universe for a number of years. And it wasn't until the start of this year, 2017, that Medicare, CMS specifically, has really started cracking down on, I would say, physicians for inappropriately billing with these 2 modifiers, but it is very significant in podiatry. In fact, I am involved right now in 2 cases, one in the state of New York and one in the state of Missouri, specifically utilizing modifiers 25 and 59 inappropriately per Medicare. With this group of podiatrists in Missouri, The Medicare contractor audited only 35 records, one date of service out of each of those medical records, covering a period of 4 years. So we're looking at 35 bills, 35 dates of service, one date of service out of each chart. They found, they being Medicare, the podiatry group, to be utilizing or using modifier 25 incorrectly 100% of the time, which is staggering. They found this podiatry group to be using the 59 modifier incorrectly 75% of the time. I did my audit, and this group wasn't real great with the 25 modifier. I was able to knock it down from 100% to 66%, which is kind of significant considering the documentation wasn't stellar. But the real interesting thing came with the 59 modifier. I was able to show in every situation that the 59 modifier allegedly or realistically was not used correctly, that it never increased reimbursement to these podiatrists 1 nickel. They didn't make 1 nickel more by using the 59 modifier inappropriately. Medicare's response to this was, well, we really don't care whether you got any more money for using the 59 modifier wrong. The fact that you were using it incorrectly indicates to us that you were on a mission to collect more money than you were entitled to. So whether you received more money or not, the fact that you billed in such a fashion, we found to be fraudulent. This is significant, and I think it's extremely important to use these two modifiers in an appropriate fashion. When you look at the most commonly audited codes in podiatry, well, of course, you're looking at the top of the list and you have 11720 and 11721, of course, the nail debridements. But right in the second slot is the inappropriate use of the 25 modifier. And it says specifically on all E&M codes. And when you go down the list, you see 11730, wound care codes, I&D of abscess, the pairing of skin lesions, corns and calluses, orthotics codes. But here, right here, in the number 8 slot, is the inappropriate use of the 59 modifier. They hate these two modifiers. As far as modifier 25 is concerned, when you look at evaluation and management codes with the 25 modifier, it is the #1 audit issue. We're not just talking podiatry, we are talking in medicine with regards to Medicare. This issue was included in the Office of the Inspector General, the OIG's work plan for 2004 and 2005. So they've been aware of this issue for 13 years, and they're still into it. Modifier 25 indicates that a significant separately identifiable E&M service was performed the same encounter that a minor surgical procedure was performed. There is not a requirement that 2 or more diagnosis codes be used in the billing of the services. And it's very subjective as to what is considered significant. But I can certainly give you guidance with both of these issues right here. When you're looking at E&M services, E&M is not a synonym for an office visit. There is no such thing as an office visit. We use the term office visit because it's habitual. We've used it for years. The term office visit was eliminated as of December 31st of 1994. 1994. There is no office visit. Office visits were very easy to bill for. You'd see the patient, you can bill for an office visit. There were 3 levels of office visits: brief, intermediate, complex, and there were 2 varieties: new patient, established patient. On January 1st of 1995, that's like 22 years ago, the term E&M came into being. It is a 2-part process. Not only do they want you to see the patient, they want medical record documentation that you treated the patient. The E stands for evaluation. Using the appropriate levels of history, examination, and medical decision-making, the 3 key components that make up an E&M service, you formulate a working diagnosis. This shows medical necessity. The M stands for management. Using the working diagnosis, you now have to do something about it. In other words, you have to treat the problem. Diagnosing a problem is not sufficient. If you treat a patient medically, you bill the appropriate level of E&M service. If based upon your E&M service, you decide it would be most appropriate to treat the patient procedurally, you may be able to bill both the E&M service as well as the procedure. And that's where the 25 modifier comes into play. I have a comment regarding time at the bottom of this slide. Not important at this point in time. Appropriate uses of the 25 modifier. In reality, there are 3 ways that the 25 modifier can be used in an appropriate fashion. The 25 modifier is used to demonstrate that a significant, separately identifiable E&M service was performed on the same day of a minor surgical procedure by the same physician. The 25 modifier is only used on an E&M service. It's E&M specific. An initial E&M service can be billed when performed on the same date of service as a minor surgical procedure code. The diagnosis code for the initial E&M service and the diagnosis code for the minor surgical procedure can actually be the same. Why can it be the same? This is the first time you're seeing the patient. You've never treated the patient previously. You do the appropriate history, physical examination, and medical decision-making. You come up with a working diagnosis. If that working diagnosis leads you to perform a procedure, then the diagnosis code for the E&M service and the diagnosis code for the procedure can be the same. And here is an illustrative example. A new patient comes in to see a podiatrist complaining of pain in her right heel. The podiatrist does the appropriate history, physical examination, and medical decision-making, and is able to justify billing a level 3 initial E&M service, a 99203, which goes on line 1 of the claim form. The associated diagnosis is plantar fasciitis M72.2. The podiatrist takes x-rays of the right foot. Why wouldn't you? 73620 or 73630 with an RT modifier goes on line 2. The associated diagnosis is plantar fasciitis, M72.2. The doctor decides to administer a cortisone injection into the right heel for this plantar fasciitis. 20550 with an RT modifier goes on line 3 with the associated diagnosis code M72.2 plantar fasciitis. On line 1, we have the 99203. On line 3, we have the 20550, which is a minor surgical procedure code with a 0-day global period. In order to get paid for that 99203, we need a modifier, and that will be 25. An established patient E&M code can be billed when performed on the same date of service as a minor surgical procedure code. The diagnosis code for the established E&M service must be different from the diagnosis code for the minor surgical procedure. There can be absolutely, positively, unequivocally no correlation between the E&M service and the minor surgical procedure. It's this issue that is the number one issue that gets us in trouble with the inappropriate use of the 25 modifier. Here's the example. That same patient comes back 2 weeks later. How's your right heel? It's killing me. The doctor does a history. When does it hurt? It hurts when I first get up in the morning and I step down. It hurts when I'm sitting for a while and then I go to stand up. The doctor does an examination, pushes on the plantar aspect of the heel, and the patient jumps, squeezes the sides of the heel, and the patient kicks. The patient still has plantar fasciitis. The doctor decides to give the patient a prescription for a non-steroidal anti-inflammatory medication. A level 3 established patient E&M service, a 99213. The associated diagnosis is M72.2 plantar fasciitis. Pretty straightforward. But then the patient turns to the doctor and says, "Doctor, since my heel is hurting me so badly, can I get another injection?" Well, you can certainly get another injection, but here's the problem. When you bill for this injection, it's going to be 20550 with an RT modifier. It would go on line 2 of the claim form with the associated diagnosis M72.2. The issue is this. The E&M service, the 99213, and the procedure, the 20550, the cortisone injection, are directly related. They can't be remotely related. They're directly related. Based upon this premise, you cannot bill for the E&M service on this day, on the second encounter with the patient for the same problem because the procedure was performed. Thus, the only thing that you can bill for with this encounter is the injection, 20550 with an RT modifier with the associated diagnosis, M72.2. But we're not done yet. The patient turns to the doctor again and says, "Doctor, I have another problem. My left big toe joint is throbbing." Never mentioned the left big toe joint, never examined the left big toe joint, never treated the left big toe joint. New problem, established patient. The doctor does the appropriate history, physical examination, and medical decision-making, and finds that the patient has painful hallux valgus of the left foot. Wouldn't that prescription for the non-steroidal anti-inflammatory medication that was originally given for the plantar fasciitis work wonderfully for the painful hallux valgus. You need to document this fact in your medical record, which will allow you to bill for that 99213 with the new diagnosis, M20.12, hallux valgus left foot. The doctor x-rays the left foot. Why wouldn't you? It's a new problem. 73620 or 30 with an LT modifier goes on line 2 of the claim form with the associated diagnosis, M20.12, hallux valgus left foot. Well, on line 1 of the claim form, we have the 99213 linked with the M20.12 hallux valgus left foot. On line 2, we have the x-rays of the left foot linked with the M20.12 hallux valgus of the left foot. And floating out here, we still have that injection that was administered for the plantar fasciitis of the right heel. That would go on line 3 of the claim form, 20550 with the RT modifier with the associated diagnosis, M72.2. On line 1, we have the 99213. On line 3, we have the 20550, that minor surgical procedure code. In order to get paid for that 99213, we need a modifier, and that will be 25. Why can we do this? Because the diagnosis code for the 99213 and the diagnosis code for the 20550 are different. And there is absolutely, positively, unequivocally no correlation between the E&M service and the minor surgical procedure. If an established patient is seen for a new problem that has never been evaluated for previously, for example, it was never mentioned, never examined, never treated. Those are the 3 key words. And a minor surgical procedure is performed on the same date of service, then not only can both the established patient E&M service code and the minor surgical procedure code be billed for, but the diagnosis code for the E&M service and the diagnosis code for the minor surgical procedure can actually be the same. And of course, the entire scenario needs to be completely documented in the E&M service for both the E&M service and the procedure. That same patient comes back 2 weeks later. How's your right heel feeling? Feels great. How's your left big toe joint? It doesn't hurt anymore. Call me if you need me. The patient comes back 2 weeks later. The patient comes back 2 months later. The patient comes back 2 years later. Quite honestly, the patient can come back 2 days later. In reality, it could be the same day the patient comes back. Doctor, I have a new problem. My left heel is throbbing. Never mentioned the left heel. Never examined the left heel. Never treated the left heel. New problem, established patient. The doctor does the appropriate history, physical examination, and medical decision-making and finds that the patient has plantar fasciitis of the left foot, is able to justify billing a level 3 established patient E&M service with the diagnosis code M72.2 plantar fasciitis. You're going to re-x-ray the left foot. Why wouldn't you? It's a new problem. 73620 or 30 with an LT modifier goes on line 2 with the associated diagnosis plantar fasciitis, M72.2. the doctor decides to administer a cortisone injection into that left heel. 20550 with an LT modifier goes on line 3 with the associated diagnosis code M72.2 plantar fasciitis. On line 1, we have the 99213. On line 3, we have the 20550. In order to get paid for that 99213, we need a modifier, and that will be 25. And those are the 3 correct ways that the 25 modifier is used. The last issue, again, is a biggie. It's the 59 modifier. Under certain circumstances, it may be necessary to indicate that a procedure or service was distinct or independent from other non-E&M services performed on the same day. Modifier 59 is used to identify procedures or services other than E&M services. So right off the bat, you're not going to put this modifier on an E&M service that are not normally reported together but are appropriate under the circumstances. Documentation must support a different session, different surgery or procedure, different site or organ system, separate incision or excision, separate lesion, or separate injury or area of injury, and extensive injuries not ordinarily encountered or performed on the same day by the same individual. And I think you can kind of see now in the description of the 59 modifier the key words: distinct, independent, different, and separate. But here comes the key phrase. However, when another established modifier is appropriate, it should be used rather than modifier 59. Thus, the physician or his or her designated appointee, that would be the biller or the coder, needs to perform a modifier search to determine whether or not there is another modifier that should be used in lieu of modifier 59. Only if no more descriptive modifier is available and the use of modifier 59 best explains the circumstances should modifier 59 be used. This last sentence sums it up. In reality, modifier 59 is never the modifier of first choice, which many of us have tagged it as. Rather, it is the modifier of last resort. How does CMS, the Centers for Medicare and Medicaid Services, know whether or not the 59 modifier is being used correctly? Well, amazingly, they have software that determines this fact. There is a 4-bullet punch list that determines whether or not the 59 modifier was used correctly. Anytime the use of the 59 modifier is contemplated, one must apply the CPT code in question, the CPT code that you are contemplating appending with the 59 modifier. You must apply the CPT code to each of the 4 bullets. If it passes 4 out of 4, it is appropriate to append the 59 modifier to that procedure code. It's an all or nothing proposition. You have to hit it on all 4. If you miss something, you can't use it. The 4-bullet punch list for the correct use of the 59 modifier. The 59 modifier is only used on a procedure code, never on an E&M code. Thus, it is a procedural modifier. The procedure code in question is a distinct or separate service from the other services performed on the same day. So not only is it a procedural modifier, it is a distinct or separate procedural modifier. In reality, the 59 modifier serves as an anatomical modifier. Why? Because there is not available a true anatomical modifier to show the carrier that the procedure code in question is a separate service from the other services performed on the same day. The 59 modifier is a multiple procedure modifier. There have to be at least 2 procedures performed. If you're only doing 1 procedure, you don't need the 59. And a good portion of the time, this group that I did the audit on was using it when they did just 1 procedure. The 59 modifier is appended to the second procedure based upon how they are listed in the CCI edits. The column 1 code does not get the 59. It always goes on the column 2 code. Don't hedge your bets by placing the 59 on all of the CPT codes that you were billing that day. Oh yeah, that group did this too. This is highly inappropriate. Here is an illustrative example. A patient is having surgery performed on his or her right foot. The doctor does 2 procedures: an Austin bunionectomy, a distal first metatarsal osteotomy / bunionectomy, and a while osteotomy on the second metatarsal. How would you bill these procedures? Well, quite honestly, the bunionectomy would be coded 28296 with the RT modifier, and the while osteotomy goes on line 2, and it would be billed 28308 with an RT modifier. Quite honestly, if you submit a claim like this to Medicare or probably any commercial insurer, you're going to be doing a free while osteotomy, because based upon the CCI edits, 28308 is a column 2 code to 28296. They are bundled together. So the question becomes, do you need to put a 59 on that 28308? Well, you take that 28308 and you take a look at the scenario that you're dealing with and the procedures that were performed for this patient. The 59 modifier is only used on a procedure code, never on an E&M code. Well, clearly 28308 is a procedure code, so you've hit the first bullet. The procedure code in question is a distinct or separate service from the other services performed on the same day. Well, the 28296 is performed on the first metatarsal of the right foot, and the 28308, the CPT code in question, is performed on the second metatarsal of the right foot. That's pretty distinct and separate. You've now hit the second bullet. The 59 modifier serves as an anatomical modifier. Well, both of these procedures are performed on metatarsals. We have 2 types of anatomical modifiers. We have toe modifiers. We have foot modifiers. Metatarsals are not considered to be part of the toe. They're considered to be part of the foot. And we've appended the RT modifier to both of these CPT codes already, and we didn't get paid for the second one. So you've hit the third bullet. And clearly, we're in a multiple procedure scenario. Thus, you're going to put the 59 on the 28308, and all 4 bullets have been met. So how would you code the scenario? Line 1 would be 28296 RT, and line 2 would be 2830859 RT. It is most appropriate, or more appropriate, to put the 59 before the anatomical modifier. The modifier that goes first shows the Medicare carrier or any commercial insurance company that it's the superseding modifier, and all modifiers that follow will follow suit. This is the only time, the 59 is the only time that a numeric modifier goes first and a letter modifier goes second. Well, not bad, 5-8. Now, are there any questions, James? James?
All right, everyone, if you have any questions, remember that you can submit them in the chat box at the bottom and submit all questions to staff. It looks like we do have our first questions. This is 2 procedures are performed at office visit. 1, a granuloma is curetted right hallux, and 2, 7 fungal nails are ground down, and a diabetic. CPT codes are 17110 and 1172159, correct? Did you get that? Dr. Warshaw, did you get that?
No, can you say it again?
It's a question. It's just asking for clarification. The person said 2 procedures are performed at an office visit. 1 is a granuloma, is curetted in a right hallux, and 2, 7 fungal nails are ground down in a diabetic, and then CPT codes are 17110 and 1172159. And is that correct?
Well, here's the issue with the granuloma thing. Medicare might just have an issue with the granuloma. They don't like to have 2 procedures performed in the nail area on the same toe on the same date of service. So what I would suggest you do is take a look at the CCI edits, and unfortunately we all have to be responsible for them, and Medicare assumes that we're going to access them. And you have to see if the nails and the removal of the granuloma are bundled together. And I would suspect that if you're doing this granuloma and you're doing the debridement of the same toenail that the granuloma is on, they're not going to pay for both, and you're going to not be able to bill for the granuloma. However, if you're doing 7 debridement of 7 mitotic nails and the granuloma is on a toe that you're not debriding the toenail on, then you would bill for the granuloma on line 2 of the claim form, and the 59 would go on there. But if they're on the same toe and the CCI edits have them bundled together, you're not going to get paid for the granuloma.
All right, it looks like we have another question from Michelle Morse. Can you bill 11719 and 11720 with diagnoses, let's see, onychomycosis and onychoincurvatum, respectively?
Okay. Here is the deal with nail debridements. 11719 and 11720 are bundled together. Since they're bundled together, you're obviously going to have to use a 59 modifier. 11720, the diagnosis code is going to be B35.1, which is onychomycosis. 11719 is for the trimming of non-dystrophic nails, any number. Generally, the two ICD-10 codes that work best with 11719 are L60.8 and L60.9, which are both nondescript, almost like a normal nail, where there is no dystrophy indicated, and of course it's not mitotic. So the way that you would bill for this, once you hook it up with your podiatric nail diagnoses, and of course, since you're going to have to use a Q modifier and a covered systemic disease in order to get paid for these, on line 1 of the claim form, 11719 is billed first with the appropriate Q modifier, and 11720 is billed on line 2 with the 59 and the Q modifier, because that's how they're listed in the CCI edits.
All right, we have another question. I believe this person's just asking for clarification on a code type. Can I bill an EM 99202 to treat an infected toe and remove an ingrown on the same toe?
Well, the answer would be yes, but Medicare is very, very slick, and very often the commercial insurance industries will follow their lead. Medicare feels, and unfortunately they are correct in this belief, that every CPT code, every procedure code has an inherent E&M component to it. In order to bill an E&M service on the same day that you are procedurally treating an ingrown toenail, you must, through the documentation of the podiatrist in the EHR, demonstrate the thought process that you used to show that that E&M service is significant and separate from the procedure. It's separate and significantly independent or identified. So if the patient came in with an ingrown toenail, the bottom line is, does the patient really know that they have an ingrown toenail? Well, no. That is why you have to do the appropriate history, physical examination, and medical decision-making to diagnose the problem. You diagnose the problem and you come up with a treatment plan. If your treatment plan is to procedurally treat the ingrown toenail, whether it's through an avulsion or whether it's through a matrixectomy, your diagnosis has to reflect that. Now, on the other hand, let me throw this at you. If a patient comes in, new patient, initial encounter, to have their nails debrided, and say it's covered, they have two painful symptomatic mitotic nails. Medicare does not think you should get paid for that E&M service with the debridement of the nails. And quite honestly, they're right. If the patient comes in to get their nails cut, what are you going to do? Work them up for their bunion deformities? Obviously not. But here's the issue. The patient comes in to get their nails debrided. The problem is they have a fungal infection. If you put them on a definitive treatment plan for the fungal infection, that is significant and separately identifiable from the debridement of the nails. And if you do that, then you can bill for the E&M service as well as the debridement of the nails. But just because a new patient comes in to get their nails debrided does not give you the right to bill for a new patient E&M service, and that's per CPT, per Medicare, and per the commercial insurance industry.
All right. Next question is prescribing an antibiotic for cellulites after an EM part of the removing an ipsilateral ingrown?
If the patient comes in and the problem, and this is not an ongoing problem, the patient comes in with a new problem and they have an infected ingrown toenail and you're procedurally treating it with an avulsion, and then as part of your examination and treatment, you're prescribing an antibiotic, and I would assume perhaps you'd also take a culture, the answer would be yes. And if it's an established patient, you can certainly justify a 99213 with a 25 modifier. And if it's a new patient, you can justify a 99202 with a 25 modifier.
All right. Does anyone else have any questions? All right. It looks like that's all the questions that we have. Dr. Warshaw, do you have anything you wanted to close out the meeting with?
Yeah, I just wanted to thank everybody for participating, and I mean, my job isn't to shake you up and upset you or make you angry or scare you, but I think it's very important to do everything appropriately. It's very easy to get paid, but it gets harder and harder to document and justify what you do in order to keep the money you were paid. And if I contributed a little bit to help you do that, then I did my job. And I thank you for listening.
And just as he said, thank you everyone for joining us. If you have any questions after the webinar, feel free to send them our way. I'm going to place this recorded webinar on ACFAOM's YouTube channel, so if you want to view it again or review it again, you will be able to find it there. Thank you and have a great day.